What is cleft lip? It is because of the error which occurs during the development of phase. To understand cleft lip, let's take a glance on embryology. So after the formation of the head fold, there are two prominent bulges seen on the ventral aspect of embryo, that is the developing brain and the pericardium. These two bulges are separated by a depression called stomodium. And here you can see the floor of the stomodium is formed by buccopharyngeal membrane which separates it from the foregut. And here is the mesenchyme which covers the developing forebrain, later proliferates downwards to become the frontonasal process. So it is stomodium and the floor is buccopharyngeal membrane. And this is the pericardial bulge. So from the front view, we can see the frontonasal process and mandibular arches on either side, and beneath that we have pericardial bulge. Little above stomodium is nasal placodes. The mandibular arch gives a dorsal bud called maxillary process. So here you can see both the mandibular arches fuses to form the lower jaw, and that projection is the maxillary bud. This is the stomodium. Above we have frontonasal process, and here the nasal placodes sink below the surface to form nasal pits. The edges of each pit are raised above the surface into the frontonasal process to divide them into medial nasal process and lateral nasal process. And the pits are continuous with the stomatodium below. When the medial nasal process and lateral nasal process fuses with each other, the nasal pit gets cut off from the stomatodium. So the mandibular process fuses to form the lower jaw, and the maxillary process now grows medially and fuses first with the lateral nasal process, then with the medial nasal process. The frontonasal process becomes much narrower from side to side when the maxillary process undergoes considerable growth, and the nasal pits come closer to each other. Now the stomatodium is bounded below by the mandibular process, which becomes the lower jaw. And in the midline we have frontonasal process, which gives rise to nasal septum, part of the upper lip called philtrum. The anterior nares, it starts to face downwards due to the growth of dorsum of nose, and cheek is formed by the fusion of maxillary and the mandibular process. And when there is any defect with this fusion, it results in abnormality. Here the maxillary process, when it fails to fuse with the medial nasal process, it gives rise to upper cleft lip, unilateral and bilateral. When the two mandibular processes do not fuse with each other, the lower lip shows a defect in the midline, which usually extends into the jaw. Non-fusion of maxillary process with the lateral nasal process results in oblique facial cleft, which runs from angle of eye to the mouth. Here the nasolacrimal duct is not formed. What are the risk factors for this cleft lip? It might be because of infection during pregnancy, smoking during pregnancy, use of certain medications during pregnancy, nutritional deficiency of the mother, particularly vitamin A and B. Some syndromes are associated with cleft lip, such as Down syndrome, Peary-Robinson syndrome, which is associated with micrognathia and retrognathia. Then Spritzen syndrome, which is associated with multi-organ disorder. What are the problems with cleft lip? First and foremost is the cosmetic problem, then difficulty in sucking, defective dentition. Such cleft interferes with dental lamina and upper incisor might be badly placed. The optimum time for repair is at the age of 3 months, and the hemoglobin level should be at least 10 gram percent. And the most common technique followed is Meralt-Blair operation, which involves 3 stages. In the first stage, adequate mobilization of the lip lateral to the cleft should be done to avoid tension on the suture line. In the second stage, the margins are made raw by cutting the whole thickness of the lip. And in the third or the last stage, the skin flaps are sutured in such a manner that the continuity of the red margin of the lip is properly maintained.